This week on the BackTable podcast,
build a program, develop an infrastructure that will support everything. Today, it's in the heme malignancy space, but in the future, I think we know that there's a lot of enthusiasm in the autoimmune space. Our solid tumor colleagues have a number of exciting CARs in the solid tumor space. And then outside of oncology, outside of autoimmune, there's another whole wave of energy around cellular therapy. So I think we're going to see growth in non-hematologic indications in the future, which will support the service line.
I'm Aaron Lyss. I'm the Senior Director of Payment and Policy Innovation with Oncology. As it relates to the discussion we're having this afternoon, I support Oncology practices in the development and growth of community oncology practice-based cell therapy programs. And I worked closely with Dr. Byrne on the development and launch of the Tennessee Oncology CAR T program. So, Mike, can you introduce yourself to the audience?
Sure. Thank you, Aaron. And thanks to the team at BackTable for having us with you this afternoon. My name is Mike Byrne. I'm a hematologist, a blood doctor in Tennessee Oncology in Middle Tennessee. My focus is in heme malignancies, and I help to launch the outpatient cell therapy program we have here at Tennessee Oncology. We are a large community-based practice. We have about 35 sites of care, about 110 medical oncologists across Middle and East Tennessee, as well as North Georgia. It's a pleasure to be with you today, talking with Aaron, a good friend of mine, about something that I think we both enjoy tremendously.
Great. So one of the important aspects of how the Tennessee Oncology program was developed and that journey is the background of those involved. You know, I can say for myself, I was brought into this initiative based on the extensive experience I'd had working with Tennessee Oncology on value-based care contracts and partnerships with payers. And the idea was that this would be material and helpful experience to developing Tennessee Oncology's CAR T program. Over time, it became very clear to all of us that the way we were going to have to structure our arrangements with especially the private payers was highly dependent on Tennessee Oncology's relationship with various other stakeholders in the system necessary to launch these programs. So, for example, the health system that Tennessee Oncology has partnered with, Ascension St. Thomas, apheresis providers, the CAR T product manufacturers. You really needed all of these relationships to line up in the same direction in order for the ultimately kind of like that final mile, the payer relationships to also work. And so over time, I got deeper into ensuring that at least the business and financial aspects of those external stakeholder relationships were aligned in how Tennessee Oncology developed its program. Dr. Byrne, I think your prior experience to Tennessee Oncology was important to, kind of the lens you took to developing the TO program and how we work together to do that. Maybe you could give the audience, kind of a little more background and context there.
I would be happy to. And before I do that, I think maybe there's one important thing to highlight in what you just said, Aaron, and that's that people think about community oncology different ways. And I think many of the people in the audience will appreciate this distinction, but community oncology, for some people is used as like a term to capture the delivery of healthcare outside of an academic or teaching hospital. And I think within that, there's heterogeneity, and there's the hospital-based programs that are not academic programs. And then there's what I think is the true community physician-owned practices that deliver oncology care that are not affiliated with a hospital. So as you were talking through some of the agreements, including with the hospital system, identifying and agreeing to services with an apheresis provider, I want to highlight that those are things that are outside of the walls of most oncology practices, certainly in the community, but maybe not in the hospital-based non-academic centers that some people still consider to be community oncology. So I went from one end of this to the other. So I started my career in an academic health system. I worked there for about 7 or 8 years. We had everything. We had radiologists, we had processing lab, we had apheresis, you name it, and it was there. I mean, we had a quality department, we had data people, we had everything. And that program started in 1980, which I used to joke, was the same year I got started. I was born in 1980. So by the time I got there, that program had been around for almost 40 years. And it ran, it was very efficient, it was very smooth, but it was very complicated, it was very heavy. And it was a allogeneic program, autologous, and we added CAR Ts later on. When I joined Tennessee Oncology about 4 years ago, I went from that big system to a very small, very quaint, but very nimble system. And I think we were able to do a lot of the setup in a very short period of time. And I was fortunate to come and meet with a group of people who had a lot of experience from other places, from other walks of life. And it made it a very, I think we were able to draw on each other's experiences and keep what we thought was absolutely essential, but some of the other things that were the result of iterating on processes over decades, we were able to either eliminate or make more efficient. So to your point, Aaron, we came and we figured out what we could do ourselves, what we had interest in doing ourselves, and what are the things that we would need to rely on a third party for, both within our practice and then as we looked at our colleagues across the street, what was the hospital capable of versus what new skill sets would we have to work together to develop to make sure that we could take care of these patients after hours and take care of these patients even during business hours when they get sick.
Yeah, I like how you started to unpack kind of the double-edged sword of the advantages and complexities of the environment you came from relative to the Tennessee Oncology experience. I know I've seen you present this slide that I really like. It's the one that shows adding a CAR T program to a, fully FACT-accredited, robust transplant program. It's like adding a story onto a second story onto a house, and then building a community-based CAR T program. And again, for the audience, I feel like we should level set. When you and I use the term community, we're really referring to physician community practice-driven cell therapy programs. The analogy is, that's a wide open grass field with nothing on it. The advantage is you get to build that foundation from the ground floor the right way, really targeted to the way you want to practice, the way your partners want to refer to the program. But you got to build that foundation. It's not already there. And could you speak to kind of how you see some of the complexities and opportunities around that paradigm?
So I think you have to be careful. I mean, we all had experiences from other places, but I think that we all recognize that other places didn't do it as well as we wanted to do it. I think the way we felt, what would differentiate us from everyone else is we could get patients through quicker. We could keep patients in our system, which is a different mindset than these academic centers, which depend on the majority of patients coming in. The majority of new patients or new cellular therapy patients are referred into the institution, whereas ours are referred from our colleagues within the same practice. So that referral pathway is a little bit different. And we had to think through the opportunities where we could gain efficiency there. So we don't review pathology. Somebody had an echo a week ago, we use that echo. There's no point in repeating the echocardiogram. And we can see there's no records transfers, there's nothing like that because it's all the same EMR. So that was one important piece that we focused on. How can we get these people through quickly? And, we always answer our phone. I don't care on night, weekend, vacation. I answer my phone no matter what to get these people through as quickly as possible. I'll overbook clinic. We can see people via telehealth if they're from a distance to do that initial introduction. Once we went live, one of our important things for us was that we all recognized the need to get a patient through, iterate, get another patient through, and continue to iterate until we got things the way we wanted them. Being in a smaller community practice like this it was very easy. I think we didn't have to run it up and down the chain of command. We didn't need administrators to review and sign off. we were able to look at things together as a team and say, where can we improve? What mistakes did we make? And make it better for the next person. And that's something now almost 2 years. We're about 2.5 weeks away from our 2-year anniversary. I mean, I think we're still improving. We're still looking for ways that we can decentralize care, get people in quicker, and make processes move more efficiently.
So what would be kind of your advice you'd give to other community oncology practices out there, to oncologists that are, joining community practices that are interested in developing a CAR T program, in the vein of the Tennessee Oncology model that we've started 2 years ago now? What are kind of some of the critical factors you see in whether determining like the right time to take that on, and how practices might engage differently with the various external stakeholders involved based on their practice?
I think my first piece of advice would be to look before you leap. Make sure that you have a pipeline to support these efforts. Make sure that you have an adequate number of patients and that you can withstand changes in the indication. That number, whatever that number is, you'll need to sustain your practice. Make sure that you're north of that, and make sure that you will have some room to wiggle as the standard of care changes. And what I mean by that is that the Tech 3, Tech 9 data with second-line teclistamab, the BCMA T-cell engager coming out, is an important component of that. So we now have these T-cell engagers. The data looks terrific. They're available in the second-line setting, and they are, in my view, very good competition, or very stiff competition for cilta-cel, which is the Johnson & Johnson second-line CAR T-cell. So J&J has the second-line BCMA space covered, but we are seeing a tremendous amount of interest in second-line, third-line tech over cilta-cel because it's easier to administer. People can get it closer to home. It doesn't have some of the other, the late neurotoxicity events that cilta-cel these are small numbers, but still there. So many people are choosing that over over cilta-cel because it's an easier, they perceive maybe a little bit safer treatment. So you want to have a program that can withstand those shifts in the standard of care, and things will change. Some of these may move into the front line, things go up a little bit. Other T-cell engagers come in the second line, things go down a little bit, but you don't want to be right on that line here. The second thing I would say is that you build a program, develop an infrastructure that will support everything. Today, it's in the heme malignancy space, but in the future, I think we know that there's a lot of enthusiasm in the autoimmune space. Our solid tumor colleagues have a number of exciting CARs in the solid tumor space. And then outside of oncology, outside of autoimmune, there's another whole wave of energy around cellular therapy. So I think we're going to see growth in non-hematologic indications in the future, which will support the service line. The last thing that I will say is that community oncology needs, we can't, in community oncology, we can't do it by ourselves. I still think we need a health system that can take care of these patients after hours. Us and many of our colleagues have elected to use a third-party apheresis provider rather than develop that in-house, and that's a separate BackTable podcast. But you need help. You can't do all of this yourself. So there is a reliance on third parties. And anytime the lawyers become involved for legal agreements, contracting, that stretches things out. And that's, I think, beyond the scope of what many of us feel comfortable doing. That's beyond our day-to-day. The last, I said last, but I have one more. This is like the footnote, is that I think the legal agreements, or not the financial component of this is very complex. And it's an extraordinarily risky service line to the practice, in that the whole cost of the drug, which is north of $500,000, is infused within 30 minutes. This is different than your X regimen where that's cost is spread over 6 cycles, 8 cycles. And if a patient loses insurance, you can pause, you can think, you can maybe delay things while they get enrolled in a charity care program or something. This is a very risky venture, and we do everything we can to make sure that the patient's insured the day of infusion, and then make sure that the case agreements and things are finalized so that we ultimately do get paid for the cost of the drug and the services we provide. Aaron, I'd be interested to hear kind of your thoughts on either on top of or alongside what I just said.
Yeah, I think your answer was very comprehensive. Tough to top that. If I were to try to answer in an elevator, I would say you have to have the team in place that's going to be able to basically dedicate themselves to this initiative. And it's a lot of people behind, working alongside us, blood, sweat, and tears, over a long period of time. You have to have the right external stakeholder relationships. Some of those can be developed as you go along. For example, the manufacturer relationships. You're not gonna have that in place before you start, but having the right hospital relationships in place before you start is either go no go, or it's the difference between the process moving faster versus slower. In the case of Tennessee Oncology, there was a long track record of partnering with Ascension St. Thomas Health on oncology service line initiatives. You can't overstate the importance of that when you go to do something as complex as this. And so with some of our practices throughout the network, we find that there is no brick and mortar apheresis location that the practice wants to utilize. And so, you have to utilize an apheresis provider that can come on site to the practice. And in some cases, it's the opposite. There's no apheresis provider that will come on site to the practice, and, they have to send patients to a separate brick and mortar location. So these are the types of, kind of constraints that are just specific to each practice environment and how they have to really work with these external stakeholders to build this. And then I think there's just this culture around, managing risk becomes like a muscle that you have to develop really out of the gate, because part of this, from my perspective, largely stems from the reimbursement for this CAR T related care and CAR T products is not always generally carved out from the provider network agreements that oncology practices already have in place with payers in their market. So now that you're outside of the contracts you already have, that makes this right there immediately very different than any other form of immunotherapy that patients can access through the oncology practice. And T-cell engagers, that's in the, that falls under the system, that falls under the contracts that oncology practices already have with payers in their market. With cell therapy being carved out from that, now you're in it's a totally different picture operationally, and a totally different risk picture that you have to develop the ability to manage and be comfortable with in order to move patients through the system.
I would agree. And I think maybe one thing that we should highlight is that this is the current state today,
Right.
And I hope, I think we're both optimistic. I think we both are part of other larger efforts to say that this can't be what it looks like for the next 10 or 15 years. And because I think it is. I mean, we recognize this. You had asked me about my life prior to coming here, and we had a whole department of people that manage these things. And I think this is a stretch for a lot of community oncology practices to invest this amount of effort into getting approval for one patient. For a one patient to get one line of therapy. So hopefully this isn't the next 5 years, 10 years from now.
Yeah, I mean, I feel like you and I probably often get asked, what are the major barriers, and as if there's a easy answer to that one. But I think the answer I would start with is the separate system that you have to go through on the private payer side to get these therapies approved and to administer them. That creates a barrier to access that is going to frustrate a lot of oncology practices that seek to develop these programs and is going to limit the options patients have in terms of where these therapies can be accessed. So as long as that's how the system looks, that these are the challenges to access that we are going to have. If we want more access points to these therapies, this system's going to have to evolve over time. So I think, you and I, we know exactly how the Tennessee Oncology model works in terms of the cell therapy program that we've developed. Let's maybe try to unpack that for the audience, for those who, like, how does this actually work? And so maybe start with pre-treatment, evaluation. How do patient candidates for these therapies surface? How are they vetted? The pipeline, committee review process, treatment selection, treatment determination, kind of how does this process start, at least at Tennessee Oncology?
Sure, I'd be happy to. And what I would try to say is how this might be a little bit different from either a current day community oncologist referring these patients into an academic center or people who are in an academic center getting these referrals and getting them through the queue. So far, we are, as I said, we're approaching our second year, and 100% of our referrals up to this point have come through our own practice. So these are patients who are established Tennessee Oncology patients who will have, ranges from I'm worried about this guy to I worried about this guy. I did a PET scan. PET scan was positive. I did a biopsy. The biopsy's back and it shows recurrent disease. So it runs the spectrum, and we have tried to be very gracious about getting these people in as quickly as possible. I told you earlier on that efficiency was how we were going to differentiate ourselves from everyone else. We've said, if it is somebody has relapsed disease and you think that they're a candidate for our chemotherapy, we give this patient our CHOP or our GemOx, even our mini CHOP. Send them to us and let us see if they're a candidate for CAR or a clinical trial. And that way of talking, I think, has resonated with a large number of our colleagues. So they are sending these people to us. They are sending these people into our center, or at least calling us about these patients. One of the first things I do is send an email or send a message to our team to see if this is somebody who is likely to be able to proceed from a financial perspective, from an insurance perspective. I will say that we are not accredited by FACT yet. We have our inspection in a couple of weeks. And the absence of accreditation has been a barrier to getting some patients care at our site. We're hopeful that will go away. But there are still some patients that we can't take care of because they're either underinsured or they have a plan that won't allow us to treat that patient. So we try to get eyes on these patients' charts, eyes from our financial team on these charts as soon as possible, preferably before I meet with the patient, so that we know how to we know how to pitch the treatment to the patient. This is what it looks like. You can come here, we can get you through, versus a little bit more of a subdued sales pitch around cellular therapy. People who cannot proceed here, we do send to other centers. So if CAR T is the right treatment for that patient, we'll do everything we can to get that patient treated with a cellular therapy. Even if it's not at Tennessee Oncology, we'll get them to another center. I take responsibility for doing that. Once our team is comfortable, as comfortable as we can be that the patient can move forward, our coordinator will start to set up apheresis. Amanda's wonderful about planning everything out. So she'll get the patient apheresis dates, she'll get them an infusion date, and then we fill everything in around those dates. We figure out if there's a plan for holding or bridging therapy. We line up the LD chemotherapy. We do everything around those two dates. While we have been open, the REMS requirements have gone away. The time at the authorized treatment center has gone from 30 days down to as little as, I think it's 10 or 14. So we tell patients that they have to have a caregiver for the full 30 days. We don't necessarily keep people for the full 30 days. We are people who are doing well, we send them home early. One of the advantages of keeping people in our system is that we can see their labs, we can see their vital signs, we can see everything in real time in our EMR. And because we can see everything real time in our EMR, we can do telehealth. And because it's all the same system, it doesn't matter where the care is provided. Whether they get their lymphodepleting chemotherapy here or 2 hours from here, it all comes from the same checkbook. So I think that those are some of the ways it looks different. And I think we're also future state. The last thing I'll add, Aaron, is that I think because we use a third party for apheresis, and because that third party has a number of other locations here in Tennessee, I think it will be only a matter of time before we're even able to decentralize apheresis from the authorized treatment center here. So I think that those are some of the big ways that we're different from the current model as it stands.
Yeah, that's helpful. The Tennessee Oncology program started with the CD19-directed CAR T cells, brought on BCMA-directed CAR T product, back in February. I know that resulted in some substantial change in how the patient is managed in the period of pre-screening, pipeline review, insurance vetting, formal evaluation. Hopefully all goes according to plan. If we need a prior auth approval, we have that. Talk about the differences in bridging and holding strategies with the multiple myeloma product relative to the way the system started for the CD19-directed CAR Ts.
I mean, as Aaron is, I think, mentioning, we started with the CD19. We had the BMS and the Kite CD19. We recently, I guess 4 or 5 months ago, added cilta-cel, which is Johnson & Johnson's BCMA product. A couple of things I think is that holding therapy is used a little bit more in myeloma, and this is even a dynamic thing because with second line, we're seeing people. We have one more options to control disease in the second line than we do in like the fourth and fifth and sixth line, like it used to be. But we're also seeing some of the late neurotox events, like the cranial nerve palsies, the Parkinson's, the movement disorders. We think that that's associated with the people that have lower tumor volume at the time of cilta-cel may have better outcomes. They have less toxicity and they may have better outcomes. And that cilta-cel, I think, in particular, has kind of shifted the way we've thought about CAR. So in lymphoma, we give it when people have active disease. It's, they may have a little bit higher toxicity. We manage it. We're pretty good at managing toxicity. We've gotten better over the last 10 years. I think cilta-cel is unique in that we think about it as a consolidative therapy that should be delivered in the optimal clinical setting. So there's a little bit higher bar to make sure that these people's disease is as low volume as possible, that they are as teed up as they possibly can be. If they have a little bit of disease, that is better than if they have a ton of disease. It's actually safer and their outcomes are going to be better. So that has led to, we've had to retrain ourselves, our navigator, our coordinator, to think about this differently, and we've had to teach ourselves to be a lot more flexible in how we plan for these patients going forward. Because if somebody doesn't have an optimal response to therapy, it may actually be better for the patient to delay their cellular therapy, to delay their infusion, do something else, try to get better disease control. And if you can get disease control, take them then when it's safer, or counsel them that there may not be a way to get better disease control and your risk of X, Y, and Z is higher. So that has changed the way we think, how we manage these patients, how long people sit in our pipeline. And it's been a little bit of a hardship because we've got in some cases, you have to cancel patients, you have to push patients out, you have to delay patients. which means you have to delay their housing, you have to fill out new FMLA paperwork for work. But it is a different way of thinking, different way of administering this therapy. And it's I think one of these things, it's a very dynamic space. Things are changing quickly, and at the end of the day, what we want is the best possible outcome for the patient. We want it, what we do has to be safe, and if there's a way to make it safe and effective, that's what we've got to do.
Yeah, I think that's helpful context for our audience. Is the next topic I'd like to go into in a little more detail, but day of infusion and post-infusion management, contrary to the way a lot of health systems and AMC-based cell therapy programs, operate. Most of the community oncology practices in the One Oncology network that are developing these programs are utilizing what we refer to as just-in-time shipping. So essentially the cells are planned to arrive on the day that the patient is going to be infused. And if there is a circumstance in which any additional, basically treatment has to be delayed for any small number of days, the plan would be to leverage the doer, shipper storage validation for that. And then send the patient home that day is always the goal after infusion. Send the patient home, keep the patient at home as long as, or when I say home could be home, or home could be the hotel, or wherever they're lodging. We've arranged their lodging for near the certified center. So talk through kind of that Tennessee Oncology's approach to infusion day 0 and post-infusion. I'll use the term monitoring loosely, not in the sense of devices, but in the sense of kind of the overall plan for managing the patient outside of the 4 walls after the infusion.
So I think one I remember, so I was a transplant provider before I came over here. And I one of the things that we always learned was you before you started chemo, you had to have the patient's cells on site. And
that was just a rule. That was a rule.
That was what you did. And we always said, well, what about like the unrelated donors? This was before COVID and the cryopreserve, before people started to cryopreserve, and people would say, well, that's different. But everything else, you had to have everyone lined up and teed up before you started conditioning. And I think that sort of naturally followed, is that even though you're not giving myeloablative chemo anymore, even with Flu/Cy, many people still thought you needed to have those cells on site in the freezer before you would dream of giving a patient a drop of intravenous anything. So we here, we don't have, we have one freezer, which is our backup freezer, and we use, as you said, just-in-time shipping. That, I think we do that for a variety of reasons. I think one of the reasons is it's more convenient, but 2, it's a way of managing the financial risk. We are responsible for those cells from the time that they are delivered to the time that they're infused. Our coordinator runs this place like a top. She gets them delivered the morning of. Within 30 minutes to an hour of opening the lid, she's got those cells in. So our financial exposure to that product is very, very low. One of the things I should have said is that we are a completely outpatient program. So patients come in the morning, they ride the elevator up, they come sit down, roll up their sleeve, get fluids through their PICC line, the cells go in, and at the end of that day, they get their education, they get sent back to wherever they came from, their hotel, their housing. And we continue to see them for daily outpatient visits until they either need to get admitted to the hospital or until they have to go home. One thing, and Aaron, you can keep me honest on this, is that I remember in our prior days when we were a hospital-based program, there's a lot of sensitivity about giving the cells and readmitting the patient within 72 hours of the infusion, because the cells, the cost of the product got rolled into the cost of the admission. We have not had that experience here in community oncology. One, these products are generally safe, and it's rare that somebody gets admitted within that time frame, but that risk doesn't that risk, to my knowledge, Aaron, and you keep me honest, is less of a consideration in the community oncology setting. We have other risks that are a little bit more unique to us, but that risk is not felt as much. We're not as leery of that risk here as we were previously. So we will continue, to see our patients for the 7 days, 10 days. We see our cilta-cells for 14. And after that, we see them generally a couple times a week until they leave our program and go back to the referring oncologist.
Yeah. So after the patient goes home, there's a fairly consistent plan on how you check in with the patient each night. Patients coming in, to clinic each day for check-in or evaluation, at least until you decide that the patient's kind of out of the woods or that isn't needed. Talk about how the Tennessee Oncology approach to monitoring patients when they're sent home or sent back to their, lodging, and how you've been able to manage these patients completely outpatient in that way, or transition them into the inpatient setting as that becomes needed. What do those processes look like?
One thing I'll say is this is a space where you can spend whatever your budget is, you can spend your budget. If your budget is a couple $100, you can put together something and do this well for a couple $100. If you're willing to make a 6-figure investment, you can find somebody that'll take 6 figures of your money and do this for you with a higher level of service. Advice I got early on was not to spend a nickel that we didn't have to keep our initial investment low, and that would keep the expectations of the service line low. That's advice that I took. We shared roles as much as we could. We kept hiring to a minimum, and we created our own nighttime system. Patients, we use our in-house telehealth platform. It used to be something else. Now it's a Zoom-based telehealth platform. We use blood pressure cuff pulse oximeter that we buy from a manufacturer, probably about $20. And then we use our in-house board Monday. So patients have access to that. They put in their vitals. Our team Zooms them with a telehealth appointment, documents in our EMR, and that's the end of it. There are more sophisticated models than that. Some have nurse triage in the middle. Some of them, you develop algorithms that they follow. That was a little bit expensive for our tastes early in program launch. And I think even now, nearing the end of our second year, I think is more money than I feel comfortable spending. So that would be my advice to people in here, is to do it in as inexpensively as possible, at least to start. The other thing I might share is that we've been very deliberate in empowering our APPs to make, developing guidelines, developing processes, developing scenarios in which patients should be admitted versus patients are acceptable to continue outpatient monitoring. And we've been very differential in their decision-making about what to do if they're worried. So I think that by developing those guidelines and then empowering APPs to make these calls, I think we've created a model where our APPs feel comfortable managing this population. They feel like they have a certain level of ownership. And I think it's made them feel comfortable, feel like this is something that they can do, so that if there is an issue in the middle of the night, 2 a.m, and one of them gets that call, I think they know, they feel comfortable managing that patient independent of us.
So we've gotten the patient treated, say things are going well up through day 10 to 14 post-infusion. Talk about the process of co-managing the patient with the referring oncologist when that's not, one of the lymphoma specialists in the practice. Mm-hmm. And how did you think that was going to go when you started the program? How did it evolve? And where do you see it going based on the experience you've had so far?
So I recently, the marketing from our colleagues in industry is that this is a one and done treatment. It's like you come, you get it done, you go home, But I recently heard it called a one and sum. So I think we give the one and then the sum usually happens after they leave. And I think there is a certain amount of supportive care that has to happen after they go home. A lot of them have low blood counts. They're on antibiotics, antivirals. A lot of them need IgG. A lot of them need vaccines. And then there's sort of this stigma. The patients have this stigma that once a transplant patient, always a transplant patient. And this is sort of like some of our colleagues think once a CAR T cell patient, always a CAR T cell patient. So they won't order scans without us agreeing. The patient can't get their hip done because they had a CAR 18 months ago and they're in remission. So I think we still provide a fairly decent amount of oversight, collaboration, especially early on, and then we see it diminish. And I've had a few people lately, that have said, I feel like I'm doing well. I feel like Dr. So-and-so is doing a good job managing me. And I said, I totally agree. And, my involvement in your care has diminished. I'm comfortable with that. Everybody gets to that point at a different time. And I think our job is to support our colleagues, to support the patients, to make sure that the specialized component of what we have done is still being done. And everybody gets there. I think it's dependent on the patient. It's dependent on the doctor that's taking the patient back.
So I think now that we've, clarified a lot of how the program works, talk about the impact you think it's had on the patient populations that Tennessee Oncology serves. We've kind of talked already, around the just-in-time shipping versus, using freezer storage for these products. Academic medical centers, hospital-based programs, there's, I'm not going to say a bad thing about how they do things. It's just there's a different way that we're doing things at Tennessee Oncology and in the community oncology setting broadly as more practices kind of go down this path. It's just different. It serves a different population of patients. It serves a different need. It has different advantages to it. And if you could kind of speak to some examples that you think kind of represent why it's been, certainly among the more motivating and heartening things that I've worked on in my career is to, work with you and the rest of the team on this program. And, are there any kind of specific cases that you think illustrate why a whole lot of people that put a whole lot of blood, sweat, and tears into this find those outcomes to be heartening?
We have a number. I think there is no doubt in my mind that we have treated patients who would not have been treated had they had to navigate a different health system, a more complicated health system. I mean, maybe I will share two patient stories briefly. The first one was a young woman with primary mediastinal B-cell lymphoma. She had a state Medicaid plan. She very untrusting of the health system. Her mother didn't want her to go. And I think the only reason that she agreed to come see us in clinic at all was because her primary oncologist in East Tennessee felt very, very, very strongly that she should at least come and talk to us. I think the reason she came is because she trusted him. And I think we were able to borrow some of his trust as we talk through what this looked like. Her mother still didn't want her to go through. I think she made the decision on her own to come through. Her mother reluctantly agreed to be her caregiver. That is somebody who I don't think, if she had to navigate a complicated pathway of having her pathology reviewed, of insurance authorization, I don't think she would have been able mentally or socially to tolerate delays in her care. I think, or a completely new everything, a new team, I don't think she could have done that. And because we were able to keep her in our system, because we were able to borrow on the goodwill of the system, of the practice, she agreed to move forward. And, she's still in remission today as a result of it. I think the second one I'll say is we had a woman come through who was illiterate. She couldn't see, she couldn't write the sentence to assess her ICE score. She was didn't have a very high level of education. And we had to think. I mean, we had to revise the ICE system or the ICE assessment. We had to think about how do we interact with this woman? How do we consent this woman? She couldn't write. I mean, we had to figure out how do we assess her function, her motor function. And we felt like we had to do that because that's our mission, right? These are the people in our practice that we want to treat. And to go back to what I said earlier about how this is, we're able to iterate on our processes, we're able to move, we're able to adapt much more quickly than a larger health system-based practice. Our team rolled up its sleeves and changed what we needed to change to get her through. And as a result of that, she's still here today. She's still in remission. And I think those are the examples. Those are people who I don't think would have been able to navigate these higher complexity systems. But
in the transition to a new care team, new setting.
But a phone call to, physician to physician phone call, next thing the patient knows that same day, she's got an appointment to come here. We get, our coordinator gets these people through quickly. And, I think I have other examples. We don't have to go through all of them, but I think there's a number of people we've seen that are, you've heard this 20%, right? Like 20% of large cell lymphoma patients who are eligible are getting this treatment. I think we are pushing, I've seen, with my own eyes, our team has seen with its own eyes that we're beyond that 20%. We're getting this treatment to patients who are outside of that 20%.
It's amazing. Hi, this is Aaron. I'm recording this outside of my interview with Mike. As you can tell, our conversation went a little long and there's a lot more on these topics that he and I wanted to cover, but we both had time constraints, so we're going to call this an end to part 1 of the discussion. We're going to do a part 2 that will be released soon, where we're going to dive deeper into some of those aspects we didn't cover.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTableOnc. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, and LinkedIn. BackTable is produced and hosted by myself, Kate Baker.
Our production team is led by Kieran Gannon,
Aaron Bowles, John Reyes,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again, and see you next time.